Okay, I think we can start. Welcome everyone to this Rapid Exchange Forum special edition. For those that are not very familiar with it, the aim of this Rapid Exchange Forum is to shed some light on international activities and expert groups that are already in place that exchange information on preparedness and learn from each other in the area of health information. The meetings create opportunities to promote collaboration and avoid duplication of work. So we will be recording this meeting. If you have any objections, please put this in the chat. And today we actually have a really nice agenda lined up for you. The theme of today is regarding resilience and health information systems. We will have 4 main projects that will be discussed, or activities that will be discussed. First, we will be talking about the COVID-19 health information system assessments that we have performed within the framework of PHIRI. And this methodology stems from World Health Organization methodology, which we've used also in several other projects and are planning on still using in the future. So one of them is TEHDAS towards European Health Data Space. And here we looked at, we used the methodology to look at countries' readiness to join European Health Data Space. Here, Shona and no, it will be Linda presenting from our unit. Then we will be presenting also the EU HIP project, in which we will be using a very similar methodology that is still under development within the HERA IT project. So this project looks at how there is interoperability with the upcoming HERA IT platform between the different member states. And then we also have the real pleasure of having Bruno Ciancio from the ECDC here with us today. He will be speaking about public health surveillance in pandemic and how to be prepared. So thank you so much. Then we'll have a very short discussion. So whenever there's questions, we can take them. This is really supposed to be interactive as well. So if you have any questions for the speakers, don't hesitate to put them in the chat or even raise your hand. And like usual, the special edition continues with an actual Rapid Exchange Forum. So in part 2, we will be having the Rapid Exchange Forum, which is chaired by Claudia Habel from GUG, Austria. Then we will be discussing some international guideline, initiative projects, and information sources that are related to the activities that will be discussed. And then we also usually look at policy and impact measures. So these are then discussed by Robert and Marilia from Hungary and from Portugal. And then usually we do a tour de table so that each of the countries have the opportunity to respond to the question. So that being said, I think we can dive straight away into our different sessions today. And Miriam Saso from Cienzano will be starting and talking about the health information system assessments we did in the framework of PHIRI, which is the Population Health Information Research Infrastructure. Don't hesitate to tweet today or to put any reflections in the chats, and the floor is yours, Miriam. Thank you so much.
Thank you very much, Petronile. Let me just switch presentation and I'll be there in a moment. All right. Okay, I hope everyone can see my screen. So as Petronile told you already, my name is Miriam Saso and I work at Cienzano, the Public Health Institute in Belgium. And today I would like to introduce you to one of the activities that we have performed within PHIRI, which is the COVID-19 Health Information System Assessment. Basically, the aim of this exercise is really to map the COVID-19 health information system that monitors the effects of COVID-19 on population health. And we really want to identify the strengths and the weaknesses in the different health information systems across Europe. The main objective is to learn from best practices, to really see in another country what has been done that other countries could learn from, but also to create capacity buildings. Basically, we are trained people to perform this assessment, to critically assess another health information system, gather insight from another country, and then also to bring those insight into their own health information system. And then we aim to provide recommendation for more health information system in Europe. The topics, so like the areas that we cover with this assessment range from data collection, analysis, reporting, knowledge translation, and governance and resources. So we really assess multiple parts of the health information system to really be able to understand how it functions and how it can improve. In our case, for PHIRI within the COVID-19 health information system. To provide a little bit of an understanding of how this process worked, as we really believe in the capacity building aspect, we always made sure that the representative of one country would be one time the assessors, so the people going in different countries to learn how a different system would work, but also one time they would be assessed. So they would have a group of experts coming in their own countries that would assess the different part of the health information system. So to just give you an example, saying that Belgium, if Belgium would be the country assessing, let's say, Malta, then the first part would be that the representative of Belgium and Malta come together and they start sharing some key reports about the health information system of Malta in general, so that the people from Belgium can start getting an understanding of how things work. And at this point in time, they also start thinking about the stakeholders, because this is the most important part. Who are the key players in the system, in Malta in this case, that played a role in the management of the COVID-19 pandemic? So who are the people that we need to talk to really understand how the health information system was organized and had to adapt in order to accommodate for the COVID-19 pandemic. So the moment that the stakeholders have been selected and the invites have been sent and accepted, then there is the part of the interview. So the Belgian team or the Belgian group performs assessments, so semi-structured interviews using an already validated WHO assessment tool that is used to assess health information system. However, in this specific case, we have adapted the tool to make sure that we could really tailor the question to the COVID-19 aspect of the health information system. So to really focus on this aspect. And then after all the different interviews have taken place with the different stakeholders separately, so that everyone can have their own time to answer the question and bring on their point of view, there is a debriefing meeting. Basically, this is an opportunity for the Belgian team that has had a lot of interviews to present the initial funding or just the main points of that have gathered during the interviews, and make sure with the stakeholders that have been interviewed that they have grasped the main concept correctly. Because with a lot of information shared, it can be easy that small things are misunderstood. So this meeting is the first feedback round where the Belgian team can really get some feedback from, in this case, the people from Malta, and then go back to actually draft the two final reports that come out of this assessment. The first one is the one-pager that basically provides really in one page an overview of all the findings from these assessments, and it covers also identified gaps and best practices that, after being reviewed by the colleagues of Malta and being approved, then it gets published and shared in the PHIRI website, or like throughout all the PHIRI stakeholders. And you can already find several of them on the PHIRI website. We will put the link in the chat in a moment. And then the second type of outcome is a report. So this is a much more in-depth report that contains a SMART recommendation and a SWOT analysis. And this is really for the use of the country that is being assessed. And this stays confidential. Now, to just show you a little bit of the countries that we have been assessed, or the numbers. So until now, we have performed 7 assessments, but we have already the next one planned, which will be Belgium being assessed by Ireland. And this will take place in April. So we really interview different stakeholders, and depending on the country, so really depending on how the health information is organized, the stakeholders that we interview are usually, for example, the Public Health Institute, the Statistical Office, but then also the people from the Ministry of Health or Research, depending on how countries are organized, but also the regional office, depending on how strong is the role of the regions in, for example, the management of the COVID-19 pandemic. So depending from the country, we have our contact person that can really point us out to who are the people that we need to talk to have a better understanding. So basically, after performing this assessment, now we have just put here for you today a glimpse of some of the best practice that we have identified. We don't have a lot of time today, but we will make, of course, sure to share with you the presentation and all the one pages that are already on the FHIRI website. But just to provide you with one example of best practice, when we did the assessment of Italy, there was already last year in January, we could really see that the country was able to capitalize on an investment that they had done prior to the pandemic. So because before the pandemic started, they had invested in having a strong vaccination system. When the vaccination delivery became one of the main policy measures to fight the COVID-19 pandemic, they could really capitalize on this because very quickly they were able to have COVID-19 added to the list of the diseases that were part of the vaccination system, and they could really easily monitor how the vaccination was going and who was being vaccinated or not, and this allowed them to put some specific policy measure in place to make sure that more people would get vaccinated. But so on one side, we have the best practices, but we were also able to identify some barriers that we saw that many of them were recurring throughout the different countries. But we have organized them in organization, technical, and legal. But just to give you an example for the technical one, we saw that during the pandemic, country had to react quickly. So everyone had to do something, and there was a need for new data. And sometimes this brought the countries to create a new IT systems. However, those usually lacked the interoperability aspect, so they were struggling to connect with systems that were already in place. And this, on the long run, can really have an issue for the sharing of data, for the linkage of data in the country, because you can have a more modern system, but it is not able to connect to the system that is already in place. But at the same time, we also saw that most countries lacked a preparedness plan specifically for the health information system. For example, we saw that new data collection were needed, but the preparedness plan that were in place, they were not providing enough guidance to the country on how to proceed. And this is something that now countries need to take in consideration for the future. And then most of them, or many of them, relied on emergency response legislation to collect new data. But this also had some issue because the moment the emergency status in a country would deem to be over, then the data collection that you were first allowed to collect then would let's say, get in danger of not being able to be utilized any longer. But so after identifying best practices and identified barriers, we also always provide the country with recommendations. So because we really want to make sure that after the analysis, we can also provide them with some concrete ways to improve. And now this is just a summary, for example, but we also know that we also realize that many countries rely, for example, a lot on paper systems, and we know how this can increase the risk of making mistakes when this paper is translated into like a digital system, and how we can have more data gaps. So we really provide them with more in detail recommendation on how to move from a more paper-based system to a more digitalized systems. But at the same time, we saw that how human resources and specifically the people that have the technical skills or technical knowledge to set up IT system were lacking in the countries. And this was a systematic problem in the sense that we also could see that just at the university level, these were all skills that were not trained in the country. So depending from the countries, also provide this type of in-depth recommendation. So I know that this is just a glimpse of some of the activities or some of the findings that we have provided in that we have found within this assessment, and we will continue to go forward with the one in Belgium. But if you have any question about some points specifically, I'm more than happy to answer them in the chat. I know that today we don't have a lot of time, or perhaps after all the other people have presented. Oh, thank you very much.
Thank you so much, Miriam. We do not see the speakers though when their slides, so maybe for the next speaker, if you can stage Miriam, that would be great. I already put in the chat the link to the one-pagers, so there's a lot of them already there. Miriam, what are we still planning on doing? Could you maybe share some of that, some of our action points for the future? Thanks.
Yes, of course. So basically now we are making the report for the assessment that we have performed in Netherlands and for the assessment that we have performed in Hungary. But we have also already planned the assessment that we will perform in Belgium. So in April after Easter, so in the second part of April, we will have Belgium being assessed by the colleagues from Ireland with the support of the colleague from Malta. So this is the timeline. And plus we are also still open to have an assessment in Greece, but this will depend a little bit on the election in the country and how the change in like in the system will take place. But we are still in contact with our people there to make sure that if there is an opportunity to perform such assessment, we will go forward with it.
Okay, great. Thank you so much, Miriam. If there are any questions, don't hesitate to put them in the chat. I think this was very intensive work, and I'm very happy that we managed to do it because I think, yeah, we haven't really taken much of the time to reflect on what has been the impact on health information systems of COVID-19 and what we can do to improve them. So it's really nice having these best recommendations, and we've received a lot of requests to actually also present them. So we will soon also be presenting them in the Parliament, and it's nice in European Parliament, and it's nice that yeah, we can have this time to reflect and use this to improve our systems. Okay, thank you so much for that presentation, Miriam. Then we will move on to the project TEHDAS towards the European Health Data Space. And in this, Linda Abbod from Cienzano will be presenting the work that we've been doing there using a similar methodology, not exactly the same, but also with very interesting results. Thank you, Linda. Over to you.
Thank you so much. Just let me share my screen. See if I can still see everybody. All right, so good morning, everyone. Thank you for being here. I will just take a very short time to present to you what we did in the TEHDAS project. So as Petronil mentioned in the morning, TEHDAS is the Joint Action Towards European Health Data Space. This was a joint action that started in 2021, and basically it was set up to support the member states and the Commission in the different options and the recommendations and elements that are needed for setting up a European health data space. So the European health data space is now something that the Commission is trying to set up to enable and facilitate better use of secondary use of health data, and to enable the sharing among the member states in the European Union. And what they're wanting to do is really to set up the infrastructure to enable that. So the TEHDAS joint action was there really to look at what are the different elements for the governance aspect, the technological aspects, and different, for example, data quality framework aspects, and how to set this up to enable the best use of such a European health data space. So what we did in our task within Cienzano is something similar to what Miriam explained for the PHIRI project. However, our aim was to really look at what the state of the play is within the different member states with regards to health data management procedures and the secondary use of health data. So what we wanted to do is really to talk to the different stakeholders and engage them. And in that way, we are enabling them to have a voice in what are the different needs and expectations at the moment, and what is the state of the play at the moment in different European health data, in different European member states with regards to a future European health data space. And here, I am really focusing on the secondary use aspect because that was the aim of TEHDAS. So what we did, we went into 12 countries in the past year, so from December 2021 to December 2022. And we had interviews similar to what they did in PHIRI, so the methodology is quite similar. We had a group of experts that went into the countries, and they had interviews with the different stakeholders to get an impression, an idea of what the situation is. So we looked at what are the different data collections in place, what are the different data quality mechanisms in place, what is the infrastructure looking like enable sharing of the data. What are the different barriers and struggles to share data among different stakeholders in the country, but within countries as well? What is the different data governance and the legal framework in place to enable the secondary use of health data? What are the different resources and needs? And then in the end, to really look at what is the political view with regards to the EHDS at that moment in the country. So we had that done. So because of the short timeline today, I will just directly dive into what our different results are. So we looked at, we tried to kind of combine this into a couple of few characteristics that we identified in the countries that we think are really important for the preparedness of the EHDS. So for example, starting with having a digitalized health data system. So we saw that in only 9 countries out of the 12 countries, they actually had a fully digitalized health system. So for example, in the Czech Republic or in Germany, they still had some paper-based health data that was in the country, and this will probably need to be changed in order to be able to join the EHDS. The second aspect that we looked at is having a common metadata catalog in place or ongoing towards setting up such a common national metadata catalog. So we think this is something that is going to be set up at the HDS, and that's why we asked about it, whether it's already in place or not. So for example, we know that in Finland there is already a metadata catalog, a national common meta catalog in place, and we have other countries that have already ongoing work, for example, in Belgium, in the Netherlands, in Denmark, in Sweden, that are working towards setting such a metadata catalog. This we need to, I need to specify here that in some cases there were stakeholders that had their own individual metadata catalog, but here we only mention the ones that had a national common metadata catalog in place or working towards it. Then the next aspect is using the having a universal, unique personal identifier for health. This is something that is very important to enable the sharing of the data in a safe way, but also linking different data sources within the country. So we saw that there were 10 countries out of the 12 countries who have a universal, whether it's an ID number, it's a social security number, or a specific health identifier number, to enable linkage in the country. So we saw, for example, that in Ireland, they don't have a health-specific identifier, nor in Germany do they use a specific personal identifier for health. The next aspect was using remote secure processing environments. So here we mentioned that there are 8 countries out of 12 that have a common use of secure processing environments. So that means in multiple of the different stakeholders, they have these environments in place, and they have the different aspects that are needed to implement this when it comes as part of the EHDS as well. The next aspect is using internationally recognized standards. So here we're talking about the different metadata standards that are internationally recognized and different data exchange standards that are in place. So for example, HL7 FHIR, DICOM, and OMOP. So 4 countries out of the 12 countries had a wide use already in place of these standards. The next aspect is semantic interoperability. So here we specifically talk about, for example, using ICD-10 or ICD-11 in some cases, using SNOMED-CT, and having those as a wide use in the country. So 10 out of the 12 countries are using these internationally recognized standards. The next aspect that we looked at is whether researchers from a different country are able to access the data in a similar way as national researchers, in a way to look at whether this enables the sharing of the data and accessing of the data between the different member states in Europe. So, for example, we saw that there are 2 countries that don't have a similar access. This is, for example, in Denmark or in Sweden, where a foreign researcher needs to be affiliated to a national entity within the country to, in the first place, be able to request access to local data. In other countries, there were very similar access procedures and access rights for foreign as well as national researchers. Then we were very pleased to see that with regards to the political will to join the EHDS, all of the countries that we have spoken with and all of the stakeholders had very positive views towards the EHDS, and that there is an added value for setting something like this up, and that there is a need to be to enable sharing of data within and between countries. And the last aspect that we looked at was, since the EHDS is being set up, we already know from the proposal for the regulation that there is need to have a contact point in the different health data access bodies. So we asked as well whether there is already an entity that is set up that could potentially take up the role of a national contact point. So we had 3 countries that have already mentioned a specific entity that is in place that will take up this role. In other cases, they have discussions ongoing, or they have ideas of who it could be, but it was not specified yet. So in this case, for example, we have in Finland, there is FinData. We have in Denmark, there's the Health Data Authority. A Health Data Authority, and in Portugal, the SPMS was mentioned that they will take up the role of a national contact point. So these are the different aspects that we had collected and identified in the 12 countries that we visited. Of course, we, as I mentioned in the beginning, the different topics that we talked about and we looked at in the different countries. So there's a lot of much more information. We have, similar to what Miriam explained, different outputs from our country visits. So on our TEHDAS website, you can see the fact sheets from the first 6 countries. So if my colleague can put that in the chat, you can already see it and see the different informations from the different topics with of the different countries that we have visited. And by March, you should be able to see the information of the last 6 countries. So you will have the full 12 countries on the TEHDAS website by the end of March or April. So we hope that you will go there and take a look at it. So just to finalize the country visits that we've done for TEHDAS. So like I said, in general, there was a positive view on the impact and the added value for the EHDS for secondary use. And there is a political willingness to join from all the 12 countries that we've had. However, similar to what Miriam presented, however, I didn't present it here in the slides, there were challenges and needs that we have also collected from the different countries with regards to be able to join such an infrastructure like the EHDS, for example, ensuring the privacy and the handling of the data in a correct way. So these are things that still need to be considered while setting up the EHDS. So like the last sentence says, one of the main aspects was ensuring data security and maintaining the citizens' trust. This was also an important aspect that was mentioned in a lot of our country visits, and demonstrating equal benefit for all member states when such an EHDS is being set up. Yeah, I think that's it from my side. If you have any questions, we are open to answer them in the chat.
Thank you so much, Linda. So what is now being planned with the European Health Data Space? And do you think any of these challenges that you have brought forward or these evolutions, are they being supported to be further developed? What is currently the plan?
So we know that during TEHDAS, the Commission has taken up a lot of our suggestions with regards to, for example, the governance structures, or with regards to the different aspects that are needed to be taken up. Within these country visits, we also looked at the different capacity buildings that are needed in the different countries, and this is being taken up by the Commission as well, considering what are the different services, central services, or additional capacity building that they need to set up to enable the EHDS. So the situation at the moment is that a proposal for the regulation has been published in May last year, and they are now in the midst of discussions within the Council, together with the member states, to finalize the regulation and set up this law for the EHDS.
TEHDAS is now coming to an end. What is the future?
So there is an EHDS pilot project that has been set up and started, I think, a couple of months ago, the end of 2022. And this will pilot the different aspects of the infrastructure for the EHDS. So to see what the added value is of having such an infrastructure to enable the secondary use of health data.
Okay, great. And I think at the moment there's also a direct grant which provides financing to countries to actually develop the health data authority or access body, which is then the point of entry for requests for data in the country. So it'll be very interesting also whether this will provide enough of the resources to be able to tackle some of the aspects where maybe some countries need to build up their expertise in their area to make European health data space functional. Thank you so much, Linda. All right, and then I will pass the floor to Shona Cosgrove. So she's our colleague also in Cienzano. And she will be sharing our experience that we want to, or the experience that we've built up through TEHDAS and PHIRI. We would like to use this also in other frameworks. So could you tell us a bit more about what HERA IT is and what some of the potential plans are? Thank you, Shona.
Yep. Thank you very much, Petronio, and thank you for having me today. So I don't actually have any slides, so I'll just be presenting. But as Petronio says, I'm presenting about EU HIP, which is a new project. We just kicked it off at the beginning of this month, so 2 or 3 weeks ago, and it's about EU interoperability with the HERA IT platform. And as Petronio mentioned, we have some ideas to kind of bring forward the methodology used in previous projects in this one. So what is EU HIP? So it's a consortium of 21 partners from 15 different countries. It's coordinated by our Danish partners at the Statens Serum Institute, co-funded under the EU for Health programme, and it's going to run for 2.5 years, so from January of this year until June 2025. I think everybody's probably aware of what HERA is, but just in case, so HERA is a new department of the European Commission. It's the Health Emergency Preparedness and Response Department. And one of the core missions of HERA is to strengthen health security coordination within the EU, both for preparedness and then to deal with crisis in crisis times. So from our perspective, the objective of the EU HIP project is because HERA is going to be building a new IT platform for intelligence gathering and threat assessment to improve readiness and be able to identify any gaps, especially in particular in medical countermeasures in future emergencies. And so with HERA building this new IT platform, of course, there's going to need to be input from the member states to make sure that the member state systems are interoperable with the new platform. And so that's the main objective of our project, is to enhance and improve the national IT systems in order to be interoperable with the HERA IT platform. Of course, the HERA IT platform is planned to be complementary to all the existing systems for early warning and response, epidemic intelligence and public health surveillance, and medical countermeasures. So I think that's part of the work as well, is to map the existing systems and make sure that they're interoperable. So at Cienzano, we have several roles within the project. So we're leading the work on identifying the specific technical needs at the national level. We're also involved in a landscape analysis of the existing systems at national level, but that work is led by our Finnish partners at THL. And then, of course, we're responsible for the national changes in the Belgian system. So in terms of how EU will contribute to resilient health information systems, I've kind of split it up into 4 parts of the methodology. So firstly, it starts with a landscape analysis of the existing systems. Secondly, identifying the specific technical needs in each country. Then thirdly, actually implementing improvements, and that work is led by our Norwegian colleagues in the Norwegian Public Health Institute. And then, of course, finally, the last step in the methodology is progressing to actually become interoperable with the HERA IT platform. So I'll just go through those 4 steps kind of in a bit more detail. So the first step, the landscape analysis. So there it's really aiming to map the infrastructures that exist, but also the actors and stakeholder networks in the different countries and the legislative aspects. So that's really to map what is happening at the moment and identify best practices and lessons learned. So this is where the exact methodology is still to be developed because the project has only just started recently, but likely it will be based on the similar approach in PHIRI and TEHDAS, but of course adjusted to the needs and the timelines of the project. And also, well, we will likely develop a tool similar to the PHIRI and TEHDAS projects to guide the assessments, building on the previous tools. We will, of course, adapt it to the specific needs of the specific topic of EU HIP. So really looking at the technical specifications for the interoperability with the IT platform. Then building on that landscape analysis, that will feed into identifying the specific technical needs in each country. So that will likely happen through country visits and potentially self-assessments as well. And so at the moment, some specific needs have already been identified by countries, but the aim is that this landscape analysis will also identify further gaps, as well as commonalities, to really create a framework for interoperability with the HERA IT platform. Interestingly as well, that we were planning to create working groups to bring together countries to analyze results, comparing the different national state of play. And also, there is a possibility for member states who are not part of the consortium to also participate and have a needs analysis performed through the Sustainability Working Group, which is part of the project, and that is led by the Finnish partners at THL. So then what I mentioned as well is that what makes EU HIP really unique is that we're actually going to be concretely implementing improvements in the different countries throughout the project towards having more resilient health information systems. So for example, some of the changes that have already been identified in Belgium is that we're going to be setting up standardized data collection from different stakeholders. So for example, laboratories, registries, hospitals and government institutions. And we're also investigating the possibility of establishing links between these different databases. So this has already been, the methodology has already been used here in Cienzano, and the aim is to extrapolate that methodology to link databases. And then, of course, as I mentioned, the fourth step in our methodology is to progress towards interoperability with the HERA IT platform. So providing guidance on the minimal adjustments and harmonization of IT systems that will have to happen to be interoperable. So that's kind of the overall gist of the project. So what the expected impact of EU HIP, what we expect it to be to achieve more resilient health information systems is that it's going to contribute to strengthening the interoperable systems to detect pertinent signals on cross-border health threats and disease outbreaks, and also to contribute to facilitating the rapid provision of medical countermeasures in crisis times. And I think what's important to note is there's a really strong focus on sustainability throughout the project to ensure that there is long-term impact towards those resilient systems. So yeah, of course, the work hasn't really started yet in the project, so that's really just a kind of whistle-stop tour of what we're planning. But feel free, I'll also put the social media channels in the chat, and feel free to let me know if you have any questions.
That's really excellent. I'm very curious how we will further shape this and get all the results in and see how we can best fit it, because of course it's still a lot of uncertainty. We still have to really define the topics, which is not easy to do since HERA is being formed at the moment, and yeah, there's a lot of different things we could do. What do you think will be the immediate first steps? And how will they be addressed with the whole consortium, do you think, Shona?
Well, just based on our kickoff meeting that happened a couple of weeks ago, so HERA are currently building the IT platform with an external agency. So I think that our immediate first steps is really to get input from their side on what is being built, to be able to know what countries actually need to do, to see what the system is, to know what we have to do to become interoperable with it. So that's going to be our very first steps, I think. And then based on that, we'll be able to map out what we need to be looking at in each of the different countries.
Do you think you will see some alignments between the activities that we've done in TEHDAS potentially with what we will see here in this project?
In terms of the findings?
Yeah, in terms of the findings.
I think so, for sure. I mean, in TEHDAS, we're mapping, we did a very broad assessment of the whole health information system and then focusing those findings specifically on the EHDS, but I think that a lot of the findings are going to be relevant because we have that very broad view. I'm hoping that a lot of those findings will be relevant to bring into HERA as well.
Yeah, and probably some of the difficulties we will see, I think, is common between, regardless what the topic of the data is, very often difficulties are seen when, as soon as you want to link certain types of information, because data sources are very often scattered at different places. So let's hope we can also provide some recommendations on how to overcome these and potentially also support the countries on mapping where precisely these issues are and how they can be addressed. Well, I'm very excited to see that. I see you put in the Twitter, so we will also keep an eye on the activities of the EU HIP. Thank you so much, Shona.
Thank you.
So then I will pass the floor to Bruno Ciancio from the ECDC. I hope I'm pronouncing that more or less correctly. Thank you so much for being with us today. And I will pass the floor to you. Thank you so much.
Hello, good morning. Good morning, Petronil. I'll try to make my camera work.
That would be great if you
Yes.
can. Yes, we
Here we
see
are.
you with a beautiful sunshine.
Yeah, and snowy Stockholm.
Wonderful.
Yeah, good morning, everyone. Thank you very much for this kind invitation. We've been collaborating actually very closely with PHIRI through the pandemic. It was an essential source of information for us and always very reactive. So I'm very pleased to be here today. Today I'm going to talk about let's see if I can share my slides. Yes, can you see them?
Not yet. Yes. All right, they're here. Perfect.
Yes, pandemic preparedness when it comes to surveillance. In the next 8 minutes, I'll try to identify what are the key maybe weaknesses that we observed in surveillance during the pandemic, and then what are the key areas for development. Now, if you look at the typical description of the various phases of the pandemic and how surveillance is meant to provide key information for action, you see that we had problems actually in all phases of the pandemic, starting with really mitigating the risk of emergence. We could not foresee actually the emergence of a coronavirus as the biggest pandemic of the last 2 centuries. And this has to do with strengthening the One Health aspect of surveillance, veterinary-based surveillance in the interface between human and animal health. I'm not going to talk a lot about this today, but it's actually something where we need to get much better. The early detection and containment didn't work so well, and I'm not only referring here to the emergence of the pandemic in China, but also in the EU, where in fact we detected the pandemic with the increased cases, so quite late since the start of transmission in the community. The comprehensive assessment, which is something that should happen at the very beginning, but then continue also through the pandemic, didn't work so well. And here I'm referring to the ability to rapidly assess key elements, epidemiological elements of the pandemic, such as transmissibility, severity, the kind of disease clinical spectrum pyramid with multiplication factors that allows you to constantly assess whether there are changes in severities and what is the actual severity of the pandemic. The monitoring phase didn't work so well because at some point, until we reached the widespread testing, we could not actually see exactly where transmission was peaking, and therefore it was very difficult to come up with more tailored interventions. But we could not also easily measure the impact of interventions, both vaccination but also non-pharmaceutical intervention. I mean, not only effectiveness, but also actually the impact on the population health. because we were lacking general population health indicators provided in real time, actually, during the implementation. And I think we are struggling also with the transition to the post-pandemic phase, where surveillance systems should continue to function, but with less resources in a more sustainable manner. So essentially, bearing in mind these weaknesses, which of course I described very concisely, but there is actually much more to say on that. I think the main priority would be to strengthen our surveillance systems for respiratory infections. We know that basically 99.9% of pandemics with the huge population impacts will be caused by a respiratory virus. Still, we don't have very strong and resilient surveillance systems for respiratory infections. And here it is one weakness, particularly when it comes to the integration between the primary and the secondary healthcare system, population coverage of primary healthcare doctors, the integration with the laboratory data, and the ability to actually continue to function in periods of crisis. So this is one key element which requires also investments in strengthening the health information systems, but also the integration of the respiratory functions within the healthcare provision system. Resilience of the system is something very important, and how do we achieve that? I think the key here is digitalization and automation, and integration. We have seen actually that countries that were able to rapidly pull together data from their hospitals and their laboratories could generate key evidence in real time. Think about vaccine effectiveness monitoring, think about ongoing assessment of severity, think about early assessment that needs to be performed when there is the emergence, for example, of a new variant. We cannot do this very rapidly unless these studies are embedded into the health information systems, and they are actually producing results in peace times. And we are actually lucky in a way that we have these viruses circulating in our countries in a seasonal way. So there is a lot that we can actually develop in peace time. Molecular surveillance proved essential during COVID. It's not, of course, new, but the potential that we have with the integration of molecular surveillance within existing surveillance systems is huge, and it plays a fundamental role also in outbreak detection and actually assessment and response. We actually were not able to effectively monitor what was the capacity of our healthcare systems in real time, and this is something that should go together with the strengthening of the surveillance systems, because the capacity in the healthcare provisions has a huge impact not only on the ability to actually reduce the impact of a pandemic, but also on the ability to effectively decide on what would be the best public health measures to implement, and for how long this should be implemented. And I think we also realized the importance of having in place complementary surveillance systems. I mentioned a few here. Wastewater surveillance is one element, but what I would like also to stress is the importance of investing in participatory surveillance. You can understand how difficult it is, especially during the pandemic, to understand where the virus is circulating. If testing is not widespread, for example, so we should use the community as a good source of information for understanding the spread of the virus. And we also do not have systems for monitoring health determinants in real time to understand where are the vulnerabilities and what are the populations that we need to protect most as a matter of priority. Now we know that even with the best surveillance systems, also in the animal-human interface, there will be pandemics. We may delay their emergence over time, but there will be new pandemics, and they are likely to start elsewhere, actually, than in Europe. And it is essential also as an element of preparedness to invest on stronger systems for detection of events and threats globally. And here we are investing on automating our epidemic intelligence functions through also the use of artificial intelligence applied to social media and eventually also on other type of media. We are in a phase where actually resources are becoming available and are available for strengthening surveillance. This won't be the case in the future, I think. So we need to actually decide now how we're going to invest. In the past 2 years, we invested quite a lot in strengthening molecular surveillance through whole genome sequencing grants, and we are now starting a training program in bioinformatics for member states. Last month, the joint action United for Surveillance started with the goal to actually strengthen member states' surveillance systems, particularly looking at One Health aspects of surveillance, outbreak detections, and hospital-based surveillance. And the Commission is also investing now 97 million to strengthen surveillance in member states through national grants and other means. And therefore, it is essential to build on what actually we know in terms of weakness, invest this budget in an effective way. And I think what was presented earlier in this meeting is actually contributing very much to understand where to invest. One element I think that is key for future surveillance systems that are resilient and effective is to increase integration. Integration between diseases, for example, between respiratory viral infections, integration between surveillance systems, and between different data sources, including immunization registries, laboratories, health information, electronic health records, etc. We need a stronger integration between healthcare levels. As I said at the beginning, it was not that easy to actually assess the severity of disease, and this really require population-based integrated surveillance systems that cover the whole disease spectrum. We need a stronger integration also between the various administrative level in the countries and obviously across sectors. And this is actually an essential weakness at the moment that we need to overcome. And I think my 8 minutes expired, so I'm happy to actually participate in the discussion. Thank you.
Thank you so much, Bruno. Very, very interesting presentation. I think a lot of the things that definitely we have also seen in the different projects we have been working on and we very much agree with. I think you mentioned, for example, we need to work on this transition to a post-pandemic phase. And that indeed we see is very difficult in the different areas because in many countries, the special status of like a pandemic led to setting up some special laws, for example, to be able to share the data quicker and link the data between these different areas quicker. And unfortunately, now that this emergency state has been taken away, it's very difficult to keep these this, I would say, a bit more fluent interaction between different data players across the whole public health area has now been a little bit set back, and it's more difficult to get access to the data again. Also, I really like what you mentioned about these complementary systems that are really needed, and that what would be really nice if we can have indeed a better view of what's happening in the community to monitor viruses in population health and to have real-time surveillance with regards to that. And I think this is really still something that is difficult to achieve, to get from these public health institutes across Europe actually have this data feed in real time. So not just monitoring hospitals, but monitoring the community. And I think that that's very difficult to do. And we, of course, we very much agree with capacity building and this increased integration. Maybe Miriam, you can stage all the speakers. In the meantime, I do have a question for you. I think it's meant for. So Luis Lapau from Portugal is asking, it seems that everyone is addressing preparedness. However, most are forgetting to communicate with each other. And communication is a core for preparedness. What is your perspective on this? So maybe you first, Bruno, and then if one of the other ladies would like to complement, we can take that one as well. Bruno, go ahead.
Yeah, thank you. Thank you. No, it's a very difficult question to answer. Of course, communication is essential. What we are trying to do is to increase communication both with our network for preparedness. During the pandemic, we had actually nearly monthly meeting with all member states involved in preparedness so that we could learn the preparedness aspects during the pandemic, also through the performing a number of in-action reviews of how the member states were responding to this. Where we are working now very closely with the Commission, with HERA. I think we need to work more also with other sectors that are not currently, where communication is not so well established. But yeah, this is work in progress. And it is a key element of preparedness. I agree.
Yeah, thank you, Bruno. And I think what we're facing also here is that when you think about that preparedness in the area of health, there's so many stakeholders as well that are involved. And so it's difficult indeed to maintain also the relationships that are then built up where the different players speak to each other. And of course, once the pressure comes for a crisis or an emergency response that is needed, everyone's under pressure and there's a lot of work to do. So it's difficult then to prioritize on communication. Miriam, you wanted to make a point?
Yes, actually, I just wanted to stress this point very much because also within PHIRI, we also made sure that we were aware of other initiatives that were doing, like they were working on this topic on preparedness and assessing the different health information system. And we have been also closely communicating with the Commission, with the G-Santé on our side to make sure that they could also use our results because they're planning to do more activities on this level to really make sure that the surveillance system in the different countries can be better prepared in the future. But this is also why we were very interested in the new project that HERA today, that Shona today presented, so the EU HIP, to make sure that what we have already learned in the, for example, the methodology methodology of the PHIRI project that has been, and in the TEHDAS joint action that has been quite successful. So that this experience that we have gathered on how to approach the different stakeholders and the network that we have created in all the different countries, because this is also what this type of assessments allow you to make, like a strong network of people that have the right expertise in the different countries, that we can bring this forward in the new project, new HIP, and target to the specific aim and the needs of HERA, because really what we want to do is that we want to help HERA to make their platform most successful.
Thank you, Miriam. And maybe Shona or Linda, how has communication been tried to, or what has been done in terms of communication within TEHDAS?
Sorry, I think my microphone was getting stuck. So within TEHDAS, we communicated with the different activities as well. So, for example, with PHIRI, we have also very much collaborated in how to set this up, and we had a training together as well. And then we also make sure that the different initiatives at EU level, so the different research infrastructure we have as TEHDAS, we have communicated with. We're trying to keep in communication with the different DGs within the Commission, but also with regards to stakeholders, we had different forums that we have set up. So, for example, we had project forums in which we had different EU projects and initiatives that are relevant for the secondary use of health information. And there we made sure that we discussed the different aspects that are relevant to the TEHDAS work packages and the work and activities that we're doing, and making sure that we're not really reinventing the wheel in many of the aspects. So we talked about the experiences, and we tried to share what are the different activities that are going, so we can learn from each other and build the work on the work that is already being done. In the same way, we had the policy forums, and in the policy forums, we had invited the different ministries. So we had actually 3 ministries. So we're not just focusing on the Ministry of Health. So we had the Ministry of Health as well as Research, but also we had the Ministry of Finances, which is very important in many of the member states as well, to discuss what are the different expectations, the different aspects, and the different needs with regards to the EHDS. And that way we were including the different layers and stakeholders in the discussions within TEHDAS.
Okay, thank you so much. So thank you so much for the speakers. Thank you, Bruno, Shona, Miriam, and Linda for being here today and sharing with us some of your activities and your perception also on how we can improve our pandemic preparedness. Now, actually, we will go straight into the Rapid Exchange Forum, where we will be seeing live how PHIRI works in terms of interacting between the member states and addressing some key policy questions that are being requested all across Europe. So I will give the floor now to Claudia to take over, and of course everybody is welcome to stay to see how this works. Claudia, over to you, and thank you so much.
Thank you, dear Petronil. I will share my slides. As you said correctly, everyone is invited to stay for the whole meeting, and I will start now. I think if you need to grab your coffee in between, it's also fine, of course. Okay, I hope you can see my slides already.
Yes, we can. Perfect.
It's not in
Correct.
this mode, but sorry, I did not mute myself. Stupid me. We should all have learned after these years, I think. Okay, but I hope you can see it like this. So first of all, the next REF meeting is on 13th of March. As regular time is always 10 o'clock. For those who never attended a REF so far, you're always invited to stay as long as you work in population health and, let's say, the public sphere. That's what, you know, the baseline, and you should be interested in population health topics. We started with corona topics a lot, but we go beyond that. And you will see also the question of today like this. We always have 2 inputs from colleagues. First, we go through a couple of events we will have, and then we go through country questions, and there's always a chance for countries also to ask sort of ad hoc questions as long as we have time, and everyone is invited of the partners to share questions, but of course to collect it nationally. We also had a lot of questions from, let's say, from our crisis response team and so on. So it's not less, can we say, as a national node, the facilitator of these things. So what is upcoming events we have besides today's special ref? There is the PHIRI Spring School on Health Information, which is still, I think, open. Luis, perhaps you can say a few words then, because it's organized from the Portuguese partners from the Universidade Nova de Lisbon, and I'm not sure if still there's a space is open.
Yes, it has been a success. We reach more than 20, 80 registration, and now it's closed. And so we are very eager to start the spring school next Thursday. I'm sure will be a success thanks to the coordination and collaboration of all partners from PHIRI. Thank you.
Thank you, dear Luis. 80 is really great. Okay, so then there is no registration possibility anymore, and those who have registered, please come and attend. Then we have submitted topics to the World Public Health Congress. We have some couple of workshops accepted, and there will be some prep meetings, and so we are quite pleased. Also, the UFA is upcoming. The UFA week, I think we should discuss today. We should submit an event. You know, it's the European Public Health Week, but I have to tell you there's also a Global Public Health Week now, not at the same time, obviously. I think we can't cover everything, but of course I'm especially Petronilio here too. Are there any plans from coordination also to do something in the Public Health Week or on this Global Public Health Week?
So we're planning on having some sessions on the health information portal. We will be having some small workshops to share our activities indeed. Thanks.
I think, yes, it should be also an opportunity perhaps for the ref to showcase what we did. And I think, again, we could also simply show the video in some of the sessions, because it's a very good video and we should make use of it, right?
Exactly. Yes, Barthélemy will be sharing it.
Very great. So we just need to register there under the PHIRI logo. So I guess we will also plan something for one day. All right. And then, so everyone is invited, of course, to contribute, or we have a small session there. Perhaps, Petronil, we can do a follow-up on this to join efforts.
Excellent.
Great. Then the Public Health Conference, UFA, is also upcoming in Dublin. We open, it's until May. I think we also have to do something, especially as Petronil succeeded on linking together, that we can charge some of our expenses for traveling there to the EU funds still, because it's like a wrap up of everything we did in the final years. So don't be shy in this. With that, I'll hand over to my colleagues. I will share the slides for Robert, but first I'll show you a topic. It's analysis of telemedicine or artificial intelligence in the countries. And these were the questions we will cover from the country rounds. Is there already some analysis of the telemedicine use or artificial intelligence use in your inpatient sector ongoing or published? And then a couple of related questions. So who did this analysis? What conceptual frameworks were used? What were the methods used? And if there are plans to carry out such studies. So this will be the questions, and our inputs always relate to these topics. So with that, I will share now the slides for, I stop for a moment and we'll share the slides of Robert. I hope, Robert, you're here already. Or you show yourself?
Yeah, I'm here. Thank you very much. And yeah, just share my slides because it's easier
it's better.
to
Yes, of course. Thank you so much.
Presentation. Thank you very much.
Thank you. We see you, and now your slides are coming as well. Excellent.
Okay.
Please go ahead.
So thank you very much, Claudia, and welcome everybody. So the topic today is the healthcare and AI and also the relation to telemedicine. I think it's a quite comprehensive and wide topic, so I just want to cover some issues related to that. The first of all, that can AI be used in telemedicine? Of course, it can be used, and practically it is facilitating a lot of issues here. And then using AI, doctors can make more data-driven real-time decisions and improve the patient's experience and health outcomes. And it has, and OECD also has got a definition about AI, because AI, I think, sometimes is a little bit obvious that what we call AI, what is deep learning and all kinds of expression like this. But according to OECD, an AI is a machine-based system that can, for a given set of human-defined objectives, make predictions, recommendations, or decisions influencing real or virtual environments. And that is also very, very important, that that kind of systems are operating with varying levels of autonomy, which is, I think, very, very important when we are making decisions and when we are investigating the relation between human and AI. There are different trends in the telemedicine using or utilizing artificial intelligence. And the four major classifications are patient monitoring, healthcare information technology, intelligent assistant diagnosis, and information analysis collaboration. So AI has got many territories and places where it can be implemented and can contribute to the results of healthcare. So my focus is mainly the recommendation, guidance, and as you said, that different initiations. And now I want to cover the WHO guidance on the ethics and governance of artificial intelligence for healthcare. And first of all, I'd like to start with a statement from Stephen Hawking, who's practically one of the most known physicists. Unfortunately, he has already died, but I think that the inheritance of that man is very important. So he said that our future is a race between the growing power of technology and the wisdom which we use it. So I think that it is very important that it is not just the system and the asset, but practically the utilization and the approach that how it is integrated into decision making. So according to that guidance, artificial intelligence has an enormous potential for strengthening the delivery of healthcare and medicine, and helping all countries achieve universal health coverage. It is very important, universal health coverage, because it is an issue of equity in healthcare. So it can benefit low and middle income countries, and especially in countries that may have significant gaps in healthcare delivery and services. AI-based tools, so using AI-based tools, governments can extend healthcare services to undeserved population, improve public health surveillance. So I think that also we get an insight from the ECDC presentation that how that health surveillance is important in the case of pandemic and other issues, and to better attend, so healthcare providers to better attend the patients and engage in the complex care. AI has a very close connection also to COVID-19 in the last couple of months, and we can say almost that year. So in that paper, this is not the exact focus, but of course has got some statements about it. But we can state that so after COVID-19, the proliferation of different usage of AI practically increased a lot. One of that is telemedicine as a part of a larger shift from hospital to home-based care with the use of that kind of AI technologies. So that WHO guidance just comes up to the issue that after the pandemic, more than 50 healthcare systems were used in the USA, and we can see that also practically it became very common also in the EU. So it accelerated and expanded the use of also medicine in 2020 and after that years. I want to also pinpoint that there is a growth in the number of text and or speech chatbots. And after that, I would like to give you a kind of example that how it really works and what are the cons and pros, and so what are the issues with that kind of technologies. According to the WHO, there are 6 core principles identified by the WHO, which should be taken into consideration when analyzing and evaluating the ethical aspects. The first is to protect autonomy, promote human well-being, human safety, and public interest. They ensure transparency, explainability, and intelligibility, foster responsibility and accountability, ensure inclusiveness and equity, and promote AI that is responsive and sustainable. And to implement all these principles, I think it is very important all stakeholders in the different processes to work together and in every phase of that flow to integrate ethical norms. It is practically just one sentence for each of that kind of principles. Protecting the human autonomy, this practically means that it doesn't undermine human autonomy, and humans should remain in control of healthcare systems and medical decisions. It's very important to satisfy regulatory requirements for safety, accuracy, and efficacy. It's very important to provide sufficient information, and it should be published or documented before the design or deployment of an AI technology. Practically, it comes up with the definition of human warranty when application of regulatory principles upstream and downstream of the algorithm by establishing principle of human supervision is very, very important. It is necessary to encourage the widest possible and appropriate equitable use and access, irrespective of age, sex, gender, income, race. And I think that it goes to the definition I started with that part. And it is very important also continuously, systematically, transparently assess AI applications during actual case and also minimize the environmental consequences. As I mentioned, that there are practically that kind of questions and concerns, and it comes up with the case of different chatbots in healthcare when AI is widely used. Here are some advantages, disadvantages. I don't want to go into detail, but what I want to do that practically, I just put 2 questions to ChatGPT, which is practically a quiet and discussed, and which is quite popular at the moment, and everybody is just dealing with it. And so the first question that I just typed in, that what medicine should I take if I tested positive for COVID? So what kind of recommendation I get and how precise is that? And you can see that so there is currently no specific medication that has been proven to cure or treat COVID-19. But there are some medication that may be prescribed to help manage symptoms. So it also gives some exact recommendations like that Tylenol and Advil, just to reduce some kind of pain. And it just makes some hints on prescription medication, oxygen therapy, and pays the attention that you shouldn't self-medicate or take any medication without consulting a healthcare provider. So practically, this is it, how that kind of chatbot works in real practice. And the second was that, do you have any ethical concerns with your activity providing healthcare-related recommendations? And you see that, the answer was that I do not have personal ethical concerns or beliefs. I'm designed to operate within ethical guidelines and principles set by my developers and the broader community. So here you can see that kind of concerns that comes up with the principle of WHO is coming up with it. So it doesn't have got that kind of ethical morale or conservativeness, but it's practically based to the programmers and for the IT guys, and also that kind of consultants who are working, putting together that kind of application. very important is that it just also makes a statement that I do not collect any personal identifiable information and I don't share any kind of information, but I think that it is, again, a very, very important issue whether that kind of statements are really true or not, or how practically that kind of data can be used, because we can see that we had that kind of approach in the case of Facebook, but later we could see that through some kind of scandals that that kind of personal data were shared in a wider territory or circumstances. Thank you very much.
Thank you very much from my end also. With this, I will hand over immediately to Maria. I think you will share your own slides. Thank you.
Okay, thank you.
I'm very impressive with the ChatGPT answers. I like them. Maria, we don't hear you yet, so perhaps you have to.
I'm so sorry. Good morning, everybody.
Very well.
Thank you, Claudia, for the introduction. Thank you, Robert, for your presentation. Thank you, everybody, for the special ref that we just had. And because today we were having two very interesting topics, and Luis is an expert in telemedicine, so that later on he will speak about it. So we tried to combine, so we will talk about the resilience of the health information systems, but with an overview also in these questions of data telemedicine. So this paper was just published now in 2023, I'm sorry. And it helps to further develop the resilience test concept methodology. And they have tried to describe the key components of a toolkit. If you would like to look at how much resilient is your health system and what can be done. So it is very interesting scientific study, and just very, very briefly, what they have highlighted, there are these 5 components. So it will be to provide a definition of resilience, which they do propose a new one, more appropriate for the specific resilience of the health systems. They also illustrate the use of a framework that they have built up, and it's my next slide. I'll just show you in a minute. They detail the main components of the resilience test toolkit that they've designed. They propose a roadmap for the test implementation, and then they propose a reflection upon the advancements and offers directions for future research and needs. So this is what they have, what they provide, and they talk about the health workforce, the technology, the information systems, the governance, the leadership, that as a core key to achieve it. Looking at the outputs, they have looked about healthcare services, the social and the community care, and the health promotion activities that will help to achieve health, well-being, financial protection, which is, as you know, what everybody advocates for a good health system, and obviously taking into consideration the efficiency of the organization. And this is not a new topic. If you see, when there was Ebola, everybody was also thinking about the resilience of the health system, about the international cooperation, about preparedness, as we have just heard in our special edition. And thinking about the resilience of the healthcare system in the era that we are right now, we have also some concepts to have in mind, as it is the digital transformation that is currently happening, the use of data, and also cybersecurity. So this other paper has been driven by the need of a better understanding of the digital transformation that is happening, and it is disruptive of the nature for the societies. So they argue that the digital transformation of the sector is not only essential, but it's also unavoidable, and it is happening. So as the process already is underway, it must be managed effectively from the perspective of cybersecurity and resilience to support the sector's anti-fragility, defined as the ability to return stronger following unexpected events. And we could see how we are right now with our research post-COVID. And they have used the pool of C-level executives from the healthcare sector in the UK, and they indicate 3 defined constructs that are meaningful to cybersecurity and transformation in the healthcare sector, which they advocate as knowledge and resources, awareness of the risk, and then partnerships and supply chain to help it to achieve it. This is another report from the European Commission in 2020 that shows us this impressive graph on how can we look at the ideal post-recovery state, and this was exactly during the first year of the pandemic, giving also the health system performance and trying to identify how resilient it is post-recovery, and as well what is the disrupted state that it might achieve. So for a reflection, health systems resilience have been on policy agendas for many years. However, little was made to implement proper structure to seriously tackle resilience. It was only after COVID-19 that the country-specific recommendations on health systems resilience have been made. And as you know, we tend to finish it up with some questions. So we would like to answer you if are we really talking about resilience seriously? How can we measure and evaluate the health system's improvement on resilience? And what is the role of partnerships and collaborations? And thank you very much.
Thank you so much, dear Maria. And regarding your question, perhaps it could be really put into the pipeline, dear Johannes, for the next one of the upcoming Rapid Exchange Forums, because I would like to expand this question even on the resilience. It covers a lot of topics, you know, from the financial stability to if it's really, are we up to the ethical standards, you know, do we really do the best for our patients? So, and how can we make it sustainable for a long time? So I think this would be really nice to cover sometime.
Thank you.
Then thanks for this, and I will go now to my slides again. Just give me a second. I have to share again, and here we go. I will now come to the country rounds. The question this time was the analysis. I hope you can see it already, the analysis of telemedicine or artificial intelligence. So was there an analysis on the use in your country's inpatient sector already? If yes, who had carried out this study? Was this more an authority or was it somebody commissioned to do it? What conceptual framework do you use for the definition of telemedicine or AI? So regarding functions like storage or monitoring or interaction for telemedicine, is there any rules or standards for prediction, diagnosis, treatments? What were the methods used in case of such a study? And if no, are there plans to do it? And also, a final question, has there been an increase in the use or implementation of telemedicine or artificial intelligence since the beginning of the pandemic? So was there a change or impact by Corona? Okay, and now go to the country round. We have 4 excused countries, which are Estonia, Germany, Ireland, and Netherlands. But Ireland, I see that as a colleague here. I only know that Eilish is on leave. So Michael, if you feel fit then to give an answer, shoot away. Otherwise, I think Eilish will respond to us. Usually, okay, let me share, I'm sharing now, so I'm not sure if I can see all the countries. This time, forgive me that. So please, I will just call everyone up, but I don't see your names this time. So sorry. I will start with UK, Ronan. Is Ronan here?
Claudia, just a small note. At the moment, we see a black screen that you're sharing.
Okay, that's not good. So then I perhaps I can, okay. I don't know what happened. I try to share again because I think it's important that everyone sees the question. Do you see it now?
Yeah, now it works.
Okay.
Thank you very much.
Thanks, Miriam, for pointing this to me. But the problem is, I try to make it happen that I see both the the partners and the screen, but it's not possible, it seems. So again, UK, I think Ronan is not here. Something today. I think Sweden also is not attending, but I think I saw Spain before. Teresa.
Good morning, everyone.
Hello.
I will send the answer because we have asked to the Department of Telemedicine here in the Institute, but we have not answered yet. So we hope we can answer you during this week.
Thank you. It's fully understandable. I think it's a tricky question.
Yes, your question. We have also several guidelines for the Ministry of Health, but we have also to read it in detail to have a response.
Of course. So then I'll hand over to Slovenia. Metka, are you here?
Metka will not be joining us today. She's on holidays, I believe.
Okay. Then I have Slovakia, Jan. No. Then Serbia.
Yes, hi from Serbia. There are certain improvements in telemedicine during the COVID pandemic in Serbia. But more data and the list of published publication I will send you by email. Thanks.
Thank you very much, Alexander. Then Romania. No one. Then Luis, Portugal, please.
Well, good morning again. Portugal has been working on telemedicine for more than 20 years, and it's mostly in the hospitals that are using this, mainly in cardiology, dermatology, and other areas. Due to COVID-19, it was a little bit spread towards primary care. Actually, our lab, our digital telemedicine lab, we are collaborating on developing a solution to link physicians from primary care to patients at home. And so there are several, I would say, several platforms that have been used for supporting physicians and nurses connecting with patients at home. Although I need to say that in Portugal, I think in most of countries in Europe, it was considered telemedicine, the use of phone calls from physicians and nurses to patients, which I don't agree, but it was considered as telemedicine. Anyway, I think it was positive because it allowed the connection between the patients and the physicians, and also pointed out the need to these sort of platforms to communicate to patients not in a presential way. In terms of artificial intelligence, we are also starting addressing artificial intelligence. We need to understand that artificial intelligence depends a lot of interoperability. It depends a lot of data quality. It depends a lot of data availability. So it's not easy to do it in healthcare. Although there are several projects going on in Portugal, we are also engaging in one of them, using data from connection between hospitals and patients at home regarding discharge, surgery discharge, and to make sure that we understand the behavior and the results from the surgery to avoid the reinternations. So we are collaborating with other partners in Portugal and in Europe, considering the use of artificial intelligence in the information that is available, but much more need to be done. That's why we are working on PHIRI and TEHDAS and all that projects in Europe, because we need interoperability so we can have data to do this. There is the main organization, SPMS, is also regulating start regulating the use of artificial intelligence and telemedicine in Portugal. It has been a slow process, but I believe with the push from the European Union, the things will go further. I need to stop here, otherwise I'll keep talking. Thank you.
Thank you, Luis. But of course, you have a lot to tell, because I think Portugal is one of the countries most advanced in this field, and I'm curious to hear more on this in the long run. Thank you so much. With that, I would hand over to Poland. I'm not sure if Małgorzata is here.
Yes, I'm here. Hello.
Hello. Hi.
Good morning. As regards the use of telemedicine and artificial intelligence, it is one of the priorities in the general policy as regards healthcare. It is also one of the priorities as regards the international cooperation with on a multinational or as bilateral relations. In Poland, we have a separate entity established, which is responsible for introducing the modern technology and the use of modern technology in healthcare, including telemedicine and artificial intelligence. Therefore, I have asked our competent department, which supervises that entity, for input. Unfortunately, I haven't received any detailed information before this meeting, so I will, of course, whatever I receive, provide to you in the written form and send it to you after the meeting as soon as I get it.
Thank you, Małgorzata. But my feeling is also from the answers we got so far, because usually we get a lot, let's say at least some answers before we have the meeting even, especially from those who are excused or so. I think there's not too many studies around, you know, on a national basis. This is my feeling, you know.
Mm-hmm.
Yeah, so don't feel bad if there's nothing.
Yeah, all right.
I think Norway is not, yeah, thanks. Norway is not here today, but perhaps we can, the Netherlands, they told us they will send some information in written. What about Malta? Neville, are you here today? Yes, I see Neville, I think. I saw you before, so I hope he's still here.
Hi. Basically, we haven't carried out any such analyses, but we are aware, obviously, that there's more use of telemedicine in Malta, especially since COVID. I think most practitioners have sort of discovered they can do more through telemedicine. AI per se, there are some attempts, so to say, early attempts in some of the public systems. I'm aware of one, for example, within the National Pharmaceutical Dispensing Network infrastructure. But otherwise, in terms of analysis per se, there is nothing really that I can report on.
Okay. I was hoping for Malta, because usually you do a lot in this field. So, but this is endorsing my feeling that it's not too much on the plate already. So coming back to other countries, I'm not sure from Lithuania, is somebody here? I'm not sure, I don't see any, I think I haven't seen, I try to remember who was here. And not from Latvia, I think, but I think I saw Luigi from Italy before.
Hi, everyone.
Hi, Luigi.
Thank you very much for the interesting meeting this morning. And about Italy, there are no specific authorities which have been commissioned to carry out specific analysis on digital tools, but there is the Observatory for Digital Innovation in Health that has published some information, and in my written answer I reported the link. And the Minister of Health has provided national guidelines on telemedicine, and has allocated a specific budget, 1 billion euros, for the creation of a national platform for telemedicine services in the Italian National Recovery and Resilience Plan. And the Presidency of Council of Ministers has set up the Agency for Digital Italy, that includes also telemedicine and digital healthcare system. In the Observatory for Digital Innovation in Health has monitored the state of diffusion of telemedicine in Italy, and has reported some data that I will report in the written answer. Regarding experiences, I just mentioned 3 experiences in the North, Central, and South Italy for the use of telemedicine in specific areas of the country. But the use of artificial intelligence for analysis of this data is not so used now at the moment in our country, except for some very, very little studies. That's about Italy, and I will send, as always, the written answer with the links and information.
Thank you, Luigi. That's great. Perhaps we can follow up with some couple of questions, because we're quite interested in the Italian system. So our colleague perhaps will address you.
Okay. Thanks
so much to Luigi. With that, I'm not sure Eilish is not here today. I know that she's on leave, but a colleague is here, Michael. Will you tell us about Ireland, or have we to wait for Eilish?
I will coordinate with Eilish during the week and get something back to you, but like from my own knowledge, there isn't a lot going on with artificial intelligence and telemedicine. We do have a national AI strategy, but not sure of anything specific for health at the moment, but we will send a response.
Thank you so much. Then I'll go again to Robert. Hungary, please.
Yeah, thank you. So in Hungary, there are a lot of different projects related to artificial intelligence and also telemedicine, but no specific authority to supervise different digital tools or telemedicine in that context. But we can find projects in cardiology, dermatology, oncology, and we can see that artificial intelligence induced lawful trends like patient monitoring, the healthcare information technology, intelligent assistant diagnosis, also in public health programs, and also information analysis collaboration in the case of different diagnosis. In Hungary, there is a quite developed EHDS system with unique social security numbers, which create the conditions to make all kinds of analysis. But I would say that they are quite sporadical at the moment. And just to give you an example, a new artificial intelligence device has been put into operation at the Semmelweis University, which can diagnose several hundred different skin diseases based on the photos submitted by the patient. So that we have got several projects like that. I will give you a kind of selected list in a written format after that meeting. Okay, thank you very much.
Thank you so much, dear Robert. With that, I go over to Greece, but I don't think Elena was here. No. Then Germany said they will give written input. Martin sent something, I think, already. But he's not here, I guess. Then France. It would be interesting this time to hear from France, but usually they do not attend lately. So perhaps this is something for Miriam, perhaps to investigate with them. It would be nice for some questions, because they're quite with Health France. You know, they have a big data hub. I think it should be, perhaps they did something in this field. Huh? Perhaps you can find out somehow.
And then, I will check on this.
Yeah, this would be nice. And I'm not sure if somebody from Finland is here. I didn't see Hanna. Is there anyone else? I think Hanna is on leave, to my knowledge. No, then I'll go Estonia. I know they have an anniversary, but perhaps someone is here. Jane excused herself. Okay, no one. Then we go to Czech Republic. I'm not sure if I saw Sarka. No. But then Croatia, perhaps. I think I saw someone from Croatia.
Hello, Emmanuel here from Croatia.
Hello.
Usually Jakov joins on these meetings,
Yes.
but Jakov is today at the kickoff in Paris, so that's why I'm coming in. So regarding Croatia, we don't have a specific governance body which would tell us to do such an analysis. But still we in Croatian Institute of Public Health plan to do such an analysis. Personally, I want to do it together with Ivan Pristaš. We are working on it. Right now we are at the planning phase to see what we are going to do and how. There is something that WHO has published. It's called Monitoring and Evaluating Digital Health Interventions, a practical guide to conducting research and assessment. We plan to see this document very, very clearly and in detail, and that should be the main document on which we will plan how to do such an analysis. We hope that until summer we will have a national analysis on the usage of digital health and AI tools in health. The other thing is that we also have a pretty strong AI platform, but which is not just for health reasons or stuff regarding health. It is called CRO AI, so Croatian AI Association, and they publish a AI map, like all the stakeholders which are taking part in the AI transformation in Croatia. The version 3 is online, and the AI tools in Croatia regarding health are also included there. Regarding the usage of telemedicine in the COVID times, we can say that yes, we see some advantages. Mostly it's about phone calls with general practitioners, which is like partially telemedicine but partially not. E-prescriptions have been on the rise since COVID. And we have some new tools that occurred during COVID. So we had Pita Štampara, which is an online platform which was made for questions regarding COVID-19. It was a chatbot using artificial intelligence, and it was implemented on a national level, supported by the government. So that is an AI chatbot which was in use during COVID. It is still in use, but people tend to use it less because COVID is not such an actual topic right now. And two other things which I have to say from the private sector. A private hospital, Magdalena, has introduced Maggie, which is also a chatbot / personal assistant for people dealing with hypertension, and it is like a triage to tell the patients should they come visit the clinic or if their prescription right now is okay. And we also have a new online platform which is launched on the 1st of December 2022. It is called DOCT. It is an online platform where people can call and have a video call with general practitioners 24/7. Of course, it is a private sector, but that is all the telemedicine and AI things we know about now. Until summer, I know that we will know everything.
Emmanuel, this is very impressive. Thank you so much. I'm quite aware that together with Portugal, Croatia is one of the most advanced countries in this field in Europe, and you proved it again this time. So thank you very much, and please don't forget to send it also in written.
Okay, thank you.
Yes, very good. So I have a couple of countries left. Bulgaria, I'm not sure if colleagues are here today. So if yes, please speak up. If not, then I hand over to Bosnia-Herzegovina. If they're here, usually they only send input in written. This time we are more delegates, so I thought. If no, I will then go to Belgium, and I'm not sure Linda or Miriam who will speak for Belgium.
It will be me, Claudia.
Please, Miriam, go ahead.
So good morning, everyone. Again, I'll be quite brief because we are waiting for the official reply from our colleagues within Cienzano that actually cover the topics of telemedicine and artificial intelligence. So the first few questions will be addressed by them. The point that I just would like to present to mention today is that COVID-19 has been a big driver within Belgium to really moving towards telemedicine. As before COVID-19, it was basically almost no telemedicine services were provided. Within the COVID-19 pandemic, they have been provided on a temporary basis, but then starting from August last year, so August 2022, public financing for digital consultation at the GP has been approved. So now the teleconsultation will be reimbursed for GP, and it will also be promoted. So this has been one of the main drivers that was able to really push forward telemedicine at the GP practice. On the inpatient sector, unfortunately, I do not have the information right now, but as soon as I receive the reply from my colleagues, I will be sharing them online by email. Thank you.
Thank you. But it also seemed there was no big study analyzing that, right?
I couldn't find it just by my own search, but I have asked the expert to make sure.
Yeah. So with that, finally, I'm not sure if Albania is here today. Because if not, I will hand over to my colleagues from Austria. I guess, Johannes, you will present the input for Austria.
Of course. Hello to everyone. I have received the following information from our data scientists. That there was a study of the use of telemedicine in Austria carried out in 2022, published recently, but unfortunately just in German. I will share the full title and a link with the minutes. The study was carried out on behalf of the Federal Ministry of Health and by the National Public Health Institute. In this study, a distinction was made according to the maturity of the application in regular care, in pilot projects and others. And also further classification was made according to the functions. On the one hand, for telemedicine, monitoring, telemonitoring, interactive services, store and forward. And for artificial intelligence, risk prediction, diagnostics, and therapy improvement. The study was carried out by desk research and web search. And expert interviews, forgotten, sorry. That's so far from our end. Thank you.
Thank you, Johannes. And I might add regarding the final question, if Corona was a boost, I would say
I
yes.
have no official answer to that question.
Yeah, my personal assumption is that at least some hospitals started also with some bots, you know, like the city of Vienna, they had a bot system in place for their whole, let's say, administrative services, and they specialized it a bit for the Corona questions. Like I think it was the Croatian example, or some countries did that also. So this is what we also know from my country. With that, did I overlook anybody? Was somebody joining now who would like to speak? I see colleagues from Slovenia, not Metka, but someone else. So if you want to share something for Slovenia, please go ahead. And there's other countries. Anybody who I overlooked, perhaps? No? If not, then please, I'm happy to close this session for today. Send us your questions as always, because the pipeline is a bit empty. If we can take on the question that Maria raised by the end of her session on the resilience of health systems, we can have it in the next meeting in 2 weeks from now at 10 o'clock. You know, it was only starting today at 9 because of the special ref. On 13th March, it's again 10 o'clock. And if we have no questions, we will cancel the meeting. But I think the resilient one could be a good one. So with that, don't hesitate to ask us questions, share your information, and have a very good day.
Thank you, Claudia, and goodbye, everyone.
Thank you. Have a lovely
Thank
Monday.
you.
Bye.
Bye.
Bye,
Thank you.
everyone.
Thank you. Bye bye.
See you all. Goodbye.